Okay. Hi, everyone. We're going to come back from lunch, so thank you for coming back. I'm here with Mihir Wag, and we're moderating the session on colon preservation. And we're going to start with a presentation about updates in colon cancer screening from Dr. Swati Patel. Dr. Patel is an associate professor of medicine here at the University of Colorado and is also our director of the GI Cancer and Risk Prevention Center, as well as being a national and international expert on hereditary colon cancer and colon cancer screening. So thank you so much, Dr. Patel.
Good afternoon, everyone. Is that microphone working? Okay. Thanks for inviting me. Really appreciate the invitation from the course directors, and congratulations on an outstanding course thus far. Really special to be a part of it. So thanks, Larissa, for that introduction. So what could I tell you in 15 minutes about colon cancer? I mean, this would probably take a 2 to 3 day symposium just to talk about the updates over the last couple of years. But I'll try to focus on some really important recent changes that will impact all of our practices. These are my disclosures, no bearing on our talk today. So thankfully, we all know that the colon cancer rates in this country have been steadily declining over the last several decades. And that's for a variety of different reasons, but at least 50% of that reduction is because of uptake of screening. And in the United States, the dominant modality that we can credit this decrease to is colonoscopy, of course. Sentinel trials published back in the 90s really have demonstrated that colonoscopy with polyp removal is associated with a significant reduction in colon cancer incidence, as well as a significant reduction in colon cancer related mortality. And subsequent large studies in a variety of different practice environments, the VA, non-VA, the US, outside of the US, have shown that colonoscopy is highly protective of colon cancer, with this most recent study suggesting that a high quality colonoscopy can protect us from colon cancer for up to 17 years after that procedure. There's a lot of interesting updates that I wish we could spend a lot of time talking about. We know that our quality metrics are likely a moving target. We all are aware of the adenoma detection rate and thresholds that are bare minimum detection rates of 25%, but there's really now significant emerging data that that's probably too low, with this study showing that in fact post-colonoscopy cancer rates are continuing to be inversely associated when the ADR approaches 35+%. So perhaps our quality metrics are evolving. In the same vein, the study published in this past year showed that serrated lesion detection rates in the right colon are also inversely associated with post-colonoscopy cancer. And in fact, individuals, endoscopists who have high serrated lesion detection rates are not necessarily completely overlapping with high ADR individuals. And so perhaps this is a distinct quality metric that we should be focusing on. We'll hear a little bit more later this session about the really impactful role of artificial intelligence in screening and improving our lesion detection rates. But in the time that we have today, what I really would like to focus on are two major gaps that remain in colon cancer screening and movement to really trying to fill these gaps in the care that we provide our patients. So the first is, as many are aware, we're observing a rising burden of colorectal cancer in young patients. And then the second, which is actually somewhat of a related issue, is that even with expansion of colon cancer screening options, we are still seeing low adherence rates, particularly in young individuals. So we know that colon cancer incidence has been decreasing in all age groups over the age of 50. And these are incidence curves that were put together by therapeutics fellow Dr. Eric Montminy and were included in our MSTF updated guidelines recently published. Unfortunately, the rates of colon cancer in those under the age of 50, both for combined colorectal cancer as well as colon and rectum cancer separated, are on the rise. What do we understand about this? Well, we know that this issue is getting a lot of attention. Many in the lay public are asking why young individuals, why millennials are getting colon cancer. And it's impacting high-profile individuals in our society. What we understand about this disease in the young is that it is quite a burden. It's the second most common cancer among those under the age of 50 and the third leading cause of cancer-related death. We've seen an over 50% increase in the incidence in young individuals and over 10% increase in mortality from colon cancer. The vast majority of cases occur in individuals between the ages of 40 and 49. And in part because we're doing a better job of screening older individuals, the proportion of colon cancers diagnosed in younger individuals is increasing, such that almost 30% of all rectal cancers right now are diagnosed in individuals under the age of 55. It's no surprise that really successively our professional societies have reacted to these epidemiologic changes. This started in 2018 with the American Cancer Society, which was the first society to really recommend decreasing the screening age from 50 to 45 for average risk individuals. And over the last year, all of our professional societies have essentially aligned behind this recommendation, including the National Comprehensive Cancer Network, the American College of Gastroenterology, and our US Multi-Society Task Force, which represents the ACG, the ASGE, and the AGA. Really, the most important change came from the United States Preventive Services Task Force, which also in 2021 recommended as a grade B recommendation to expand screening to 45 to 49-year-olds. Why is that important? Well, under the Affordable Care Act, any grade A or grade B recommendation from the USPSTF really requires no cost sharing with the patient. And so this is a very, very important designation with the USPSTF supporting colon cancer screening as a grade B recommendation. Therefore, individuals aged 45 to 49 should not bear any cost sharing, no kind of towards their co-payments, deductibles, or require coinsurance to get screening. Unfortunately, we still fall short of screening rates. This is a summary of screening rates across our country in those 50 and older. And if we look at Colorado, less than 70% of eligible individuals are getting screening. And this doesn't even include the recent expansion to younger individuals. What's even more disheartening is that when we break down the data by age, only about 50% of eligible individuals aged 50 to 54 are actually getting colon cancer screening. So adherence and really uptake of screening is a major, major issue. So what are our screening options? Well, we're all familiar with kind of the big categories of options that we have. Blood tests, stool-based tests such as the fecal immunochemical test or a combination of FIT and fecal DNA, as well as our structural tests, including colonoscopy. What's the best test? Well, it depends on how you define best. When we think about a screening program on a societal level, ideally a successful screening program should include a disease that it has a high public health burden, can be detected in a preclinical phase, either in a phase that's a precancerous phase or even early cancer stages. And it should be a disease in which early detection actually improves our patients' outcomes and their lives. Furthermore, it should be a disease state wherein we have tests that we can actually have high sensitivity for detection of these early preclinical stages. And it should be a test that's ideally acceptable, affordable, and accessible to the population. And these factors really are what makes a successful screening program. So when we think about these tests, it's important to sort of understand where along the precancer cancer spectrum these tests are designed to really detect colorectal cancer or precancer. The structural tests, as we know, such as colonoscopy, of course can detect cancer, but also have the ability to detect precancerous polyps. On the other hand, stool-based tests are generally designed to detect early stage cancers, ideally. And then we'll talk about the recent updates, but historically the blood-based tests have not been very encouraging because they've only detected kind of late-stage invasive cancers. So when we think about what the best test is and what we have true evidence for, we actually only have prospective randomized control trial data for the old guaiac-based fecal occult blood testing and flexible sigmoidoscopy. We have very strong cohort data for both colonoscopy as well as fecal immunochemical testing, but for a lot of these other modalities, the data on whether this truly impacts incidence and mortality in populations is still missing. So when we think about colon cancer, clearly this is a disease that is a high burden to our society. We can detect it in early stages where outcomes are very good for our patients, and maybe even in the precancerous phases of polyps where we can actually prevent cancer altogether. So the disease state is very well positioned for cancer screening. How about our screening tests? What are their test characteristics? Well, when we compare them across the board, you can see the sensitivities listed for cancer, for advanced adenomas, and advanced serrated lesions. And there's really no doubt that colonoscopy appears to be the superior test for detection of cancer and clinically significant precancer. But with that said, why is over half the population almost of younger individuals not really taking colonoscopy as an option? Well, this is an interesting study that essentially randomized patients to being offered colonoscopy screening, sequential screening, meaning a colonoscopy, and if they declined colonoscopy fit, or a choice between the two. And what they found was that participation rates varied significantly. So there was a low participation rate of about 18% for colonoscopy and about 26% for either the sequential approach or the choice approach. Interestingly, out of all of these three groups, the advanced lesion detection rate was the same. And so this just highlights how important the adherence to the test that actually gets done on a population-based level, can really impact the lesion detection rates and how much we're actually finding disease at early stages. So the reality is, when we're talking about these test characteristics and trying to determine what the best test is, not only do we have to think about the accuracy of these tests and sensitivity for picking up the disease, but we have to think about some of these other factors: cost, adherence. So when we think about what the best test is, in the context of these low adherence rates, the good news is we have multiple large prospective randomized controlled trials that are underway that really are designed to compare different screening approaches: colonoscopy versus annual FIT, colonoscopy versus biennial FIT, versus a variety of other designs that you can see here. And over time, in the next 5 to 7 years, we will have data on a population level as to which approach actually decreases burden of disease in our patient populations. But with that said, based on the evidence that we have, as we all know, our current guidelines support a menu of options and really leave it to shared decision-making between the patient and the provider as to which one to proceed with really the idea that the best test is the test that actually gets done. It's important to note that when we think about the various screening options available to us, these are all considered two-step tests, meaning if any one of these tests, except for colonoscopy, is abnormal, it does require a follow-up colonoscopy to determine why. And a recent challenge that we've been facing is that patients have been met with cost and barriers to getting that follow-up test, where various insurance companies have coded this as a diagnostic test as opposed to completion of screening. The good news is that the Biden administration in January of this year essentially made a decision that this doesn't necessarily have to be the case, which I'll review with you. So when we think about cost, even though the USPSTF recommendation supports no cost sharing, we know that there's an opportunity cost with the tests that we offer. Patients have to take a day off of time, life, work, family obligations to get their procedure. There's all sorts of other barriers that some of our patients encounter and cite. Is there a better option out there that could be more acceptable to our patients? This was a study that surveyed approximately 170 individuals and offered them colon cancer screening via colonoscopy. 37% accepted that option right out the gate. 63% declined. Of the ones who declined, really only 3% actually refused screening altogether. The remaining individuals who refused colonoscopy were offered a non-invasive option. Of those, 15% were interested in a fecal stool test, and 83% actually preferred a blood test if it were available. So I've shown you that there is a blood test available, and in fact, the Septin9 test is approved by the FDA, but you didn't see it in any of the menu of options that our guidelines currently support. Why is that? Well, Septin9 essentially takes advantage of circulating free tumor DNA and is a PCR-based test to detect kind of this cell-free DNA in the blood. And even though conceptually it seems very sophisticated and a good way, a non-invasive way to possibly detect cancer, the test characteristics are quite disappointing, right? To actually make an impact for our patients, we want to detect cancer at early stages. And the sensitivity for septin-9 and even the next generation of that test is pretty poor, only picking up to 64% of stage 1 to 3 patients. So the FDA essentially said that, look, before we can entertain another blood-based screening test, there's certain criteria that these biomarkers have to meet. They have to, of course, be authorized by the FDA, and they have to show a sensitivity of greater than 74% and a specificity of greater than 90%. So these are the benchmarks that our government has essentially put forth before CMS will cover these types of tests. So what's really exciting and updates that I want to share with you are developments in this area. And there are certainly some of these tests that I'll tell you about that are currently under FDA approval right now that we'll see probably emerge within the next year or so. As I said, historically, we've always thought of these blood-based tests as only being effective at detecting these late-stage cancers. But the good news is that actually some of the newer tests that are under study show much more promise. So these tests in concept are similar to the septin-9. They, of course, pick up some of this free tumor circulating DNA, but also pick up epigenetic changes, so methylation markers that are associated with tumors, and then also various inflammatory cells that can be associated with tumors, so protein-based tests. And so there's multiple assays that are currently now under study and will soon be available. And these tests, when we look at how they perform, are actually very, very encouraging. And so looking at stage 1, stage 2 disease, one of these assays essentially had a sensitivity of 88 and 98% respectively. And in individuals diagnosed with cancer that did not have any symptoms, the sensitivity for early stage disease, stage 1, stage 2 disease, was 90%. This is outstanding. It's better than FIT. It approaches FIT fecal DNA. The specificity when looking at these multi-omic type tests is quite good and uniformly performs better than fecal immunochemical testing or the old septin-9 test. What's really, in some ways, a brave new world is that these tests are not necessarily specific to colorectal cancer. And so they do actually have sensitivity for a variety of cancers across the board. So to finish up, we're going to see new two-step tests emerge. And I think the kind of biggest disruptive change in screening will be the emergence of blood-based screening as one of those two-step tests. We'll continue to encounter challenges with these two-step tests. Of course, it requires adherence to more frequent testing than colonoscopy every 10 years. There's cost associated with these tests. The test is only as effective as we can get the positives or the abnormal tests navigated to colonoscopy, coverage for a follow-up colonoscopy, as well as discordant results. Just to highlight a few of these issues, navigation to colonoscopy, this is critically important. The blood-based test alone is not going to affect a patient's outcome unless they're able to get a follow-up colonoscopy. And we know that delay of colonoscopy after an abnormal stool-based test is associated with more advanced stage disease. Our professional societies recognize this and in fact recommend specific navigation measures to ensure that patients with an abnormal first step test get sent for their colonoscopy. Coverage for follow-up colonoscopy. This is an issue that many of us in practice have encountered where an abnormal FIT test is considered the screening test, and then the insurance company will say, well, that follow-up colonoscopy is diagnostic now. And so the patient does have to share cost with going towards their deductibles or have to pay a copay. As I mentioned, in January of this year, the Biden administration essentially put a clarification out to say that really payers cannot impose cost sharing and that the second step, the colonoscopy, is considered completion of that screening process and required payers to essentially be adherent to this mandate by May of this past year. Now, with that said, the challenge is not over. This is actually just a statement that the AGA put out in the last day or so, where the Supreme Court in Texas is trying to rule coverage for colon cancer screening under the Affordable Care Act as unconstitutional. So the fight will continue to ensure that our patients don't have to bear too much cost with screening. What do we do with discordant results? If that first test is abnormal, but the follow-up colonoscopy doesn't show anything of concern? Well, it's certainly a concern with these circulating blood tests, but even with fit fecal DNA, this study really showed that individuals who had an abnormal fit fecal DNA but a normal colonoscopy actually had a very low risk of having a cancer. And therefore, really, our societies recommend that if the individual has a follow-up high-quality colonoscopy, they don't need to go any other testing, even if that initial test was abnormal. So just to wrap up, where I see things going with colon cancer screening with some of these high-level updates, we know that colon cancer rates are increasing in young individuals. And though it's a really important first step to expand the eligibility for screening to these younger individuals, it will be highly dependent on adherence. And we know that adherence, even in the 50 to 54-year-olds, is quite low. And so I see this as a great opportunity for some of these two-step tests like blood tests that can be much more attractive to younger patients. I really don't think colonoscopy is going anywhere. It's just going to be different. We're going to have different quality metric targets. It may be more likely to evolve into a therapeutic test as opposed to an average risk screening test. And I think we're going to continue to struggle with desynchronous two-step tests when the results are disparate between the initial test and the follow-up colonoscopy, as well as cost to the system. So I thank everyone for their attention. I'll just call your attention to save the date. In a couple weeks here, we're hosting Dr. Finn McRae from Australia. He's an expert in hereditary cancer syndromes, and he'll be giving us a talk as part of the Anand lectureship. If you'd like more information, you can contact us. Christy Click can provide that, as can I. And I thank everyone for their time and attention.